Myself, Dr. Prakash Kumar Prusty, Senior Consultant Diabetologist, Cuttack, Odisha. Today, I will discuss first a case, then I will discuss the interpretation. So coming to case history, a 68 years old woman returns to her clinic for a follow-up visit at 3 months after initiation of empagliflozin 10 mg per day for her type 2 diabetes. Her glucose levels have improved, but she complains of vaginal pruritus and is worried that he has a yeast infection. You diagnosed vulvovaginal candidiasis in the patient and prescribed a single dose of fluconazole 150 mg. After reviewing her laboratory test results, you notice that since starting empagliflozin, her HbA1c level has improved slightly from 8.9% to 8.2%. But she needs to be more improvement in HbA1c target. Her eGFR is 69 ml per minute for 1.73 meters square. So the final diagnosis was poorly uncontrolled diabetes in a woman patient with genital tract infection. Now coming to discussion. SGLT2 inhibitors is an increasingly important oral medication class in the type 2 diabetes patients, with their use climbing dramatically in recent years. They result in a broadly similar amount of glucose lowering compared to other oral agents, but can also reduce blood pressure as well as weight reduction. In addition to their glucose lowering effects, large-scale clinical trials have demonstrated reduction in CV outcome as well as renal outcomes in high-risk diabetic patients, as well as benefit in patients with heart failure in both diabetic as well as in non-diabetic patients also. SGLT2 reduces hyperglycemia in people with diabetes by increasing urinary excretion of excess glucose. This induced glycosuria increases the risk of genital infections. In both clinical trials and observational studies demonstrate it is 2.5 to 6 folds increase in genital infections in people using SGLT2 inhibitors compared with control. The development of genital mycotic infection is more common with SGLT2 inhibitors. Incidence is 4% to 6% compared to other oral hypoglycemic agents, and can dissuade patients from persisting the treatment. A number of factors have been shown to be associated with risk of genital infections in the general population, in particular female sex, uncontrolled diabetes. The combination of SGLT2 inhibitors and DPP4 inhibitors offers a suitable component in strategy to achieve target HbA1c without increased risk of hypoglycemia and weight gain, with improvement in overall lipid. A reduction in the incidence of genital infections associated with SGLT2 inhibitors has been reported when a DPP4 inhibitor is added, perhaps because of better glucose control, although other possible mechanisms remain to be investigated. In clinical practice, the risk of genitourinary tract infection may be a barrier preventing patients from receiving or continuing a potentially life-saving therapy. In addition to local hygiene consultation on how to prevent genitourinary tract infections, identifying combinations therapies that limit the risk of such acute exacerbation is an interesting strategy. The putative mechanisms therapy, DP4 inhibitors, may moderate SGLT2 associated genitourinary tract infection risk, deserve some components. By far the most straightforward explanation is that DPP4 SGLT2 inhibitor combination reduced glycemia as well as glycosuria more than SGLT2 alone, thereby resulting in protection from genital tract infection. DPP4 activity is present within some yeast molds as well as in bacteria, and its inhibition may directly modify microorganisms function. These highly speculative and sophisticated hypotheses need to be tested experimentally. Thank you.